Hi, friends, and welcome back to the Hippie Martha Hormone Hour, the podcast where we reconnect women with their bodies through body literacy, hormone education, and a root cause approach to health. I'm so glad you're here because today's conversation is one that I know so many of you have been requesting. Today's episode is called From Surviving to Thriving in Midlife. Perimenopause has a way of making women feel like they've suddenly been dropped into a body they no longer recognize. Maybe you're exhausted even after a full night's sleep, waking at 3 a.m., noticing brain fog, mood changes, shifts in your libido, bladder symptoms that aren't quite a UTI, or wondering why things that used to work for your body just don't anymore. You may gaslight yourself saying, this must just be what getting older looks and feels like. I want to challenge that and say that is not always the case. Your body isn't failing you. Yes, it's changing. Just like in puberty, we go through our weird, awkward phase and come out on the other side. However, the more we understand those changes, the better we can support them through and thrive, both during and on the other side. Today, I'm joined by Dr. Christina Enzmann, a board-certified OB-GYN, certified menopause practitioner, and functional medicine physician who specializes in helping women navigate perimenopause and menopause through both evidence-based medicine and a whole-person root cause approach. Together, we're diving into stress physiology, blood sugar regulation, sleep, gut health, hormone replacement therapy, genitourinary health, what testing actually matters, and perhaps most importantly, how women can move from simply surviving this transition to truly thriving on the other side. Dr. Enzmann, thank you so much for being here today. I'm so glad that you reached out.
Yeah, I'm all excited. This is all good topics. Let's get it going.
Yes.
My most beloved topics to talk about. All of them.
Wonderful. So for my regular listeners, we usually begin each episode with a cycle day check-in. And for a moment, if you're listening, I want you to pause and notice what your body is telling you. You can kind of gauge what cycle day you're on. But in this episode, since Dr. Enzmann is post-menopausal, she doesn't have a cycle day check-in. So I wanted her to share a simple way that she or other women post-menopausal can check in with themselves each day to maintain that sense of body awareness and bodily autonomy, even when you no longer have a menstrual cycle to guide you.
Yes. So yes, ladies. So I have normal menstrual cycle and it's fantastic. So I know most of you are on a different phase of life and that is good. But I'm just telling you, this is also very good if you have no more menstrual cycle. So I wake up every morning. I always say it's the same Christina. There's no cycle day. It's always myself. I check in, do I feel fatigued? Do I have any aches? And I want to tell you that postmenopause is not about being achy, but sometimes, I have worked out too hard or I didn't eat the right thing. So I check in, how is my energy level and what is the outlook of the day? That's how I check in with myself. And I check in, how do I feel about things? And, some of you have more anxiety. I think in the morning, that's a good moment to check in. And really, that's that. It's fantastic. So once you have a normal cycle, don't worry about it. It's also just fine. It's just different.
I love that. I think you can still have the autonomy and just knowing that, like you said, our hormones are more stable postmenopausal because, they are lower. And so that can kind of indicate how we feel and have just more stability versus it changing, like you said, day to day.
I like the word autonomy because, I always say, and of course, my patients are older, so I need to reassure them. They are often worried my cycle goes away, all of that. So I'm always telling them, look, your hormones, they have a way to hijack you. They hijack your hormones, your function, they want you to reproduce. So they're doing all kinds of things with you throughout that hormonal menstrual or monthly cycle. So that falls away. And I'm always saying, postmenopause is the moment when women start tolerating much less nonsense in their life. For that reason, like that filter kind of goes away that takes you on a ride all your life. So I would say autonomy is good because you wake up in the morning and you know exactly what's going on. You're like, do not bother me with nonsense. You get a very clear view on your life that I feel, and there are some, some clarity. So thank you for,
Yes.
I think that's important to know.
I get a lot of questions. Am I in perimenopause? And I guess for new listeners, I did address this in episodes 24 and 25. So if you want to go back and listen to those of how to identify when you could possibly be in perimenopause. But what do you see women coming into because you still practice, right? On
Yes.
Fridays, you have like a practice.
Yes.
What do you usually see women in their 40s and 50s coming into your office with?
Well, they have like the early signs of perimenopause. It can be they get more anxiety, they sleep poorer, their cycle becomes more erratic, there's some cycle irregularity. Some women get what's supposed to be a late sign of menopause. They actually get urinary tract infection or vaginal symptoms, I want to say, pain with intercourse, some dryness, very subtle. And they are, they feel fatigued, and they're often told by their gynecologist, it can't be perimenopause because you still have regular cycles or you still have cycles. And that's just not correct. And I always say, well, perimenopause takes 8 to 15 years. There's an early perimenopause, later, there are different stages. So anyone who's kind of over 40, I'm like, just by your age, you're in perimenopause. There's no doubt about it. And then these, how much symptoms do you have? That is very individual. However, there are stages from slight cycle irregularity. And then, once you start skipping cycles, then, we put you more in the late perimenopausal transition. However, I have to tell you, every woman does that differently. Some women really have a normal cycle and suddenly it stops and that's the end of it. That is rare, but that happens too. And other, skip cycles, then it comes back for a couple of years again, and then it kind of tears out. So there's all type of variation, depending on your genes, your stress level, your hormones, all of that.
Also, talking to that menopause can happen surgically or medically too. So, women who have had their uterus removed early on, that is also considered, it's post-menopause. So surgically, it can happen. What do you think about those who have their ovaries left? Do you still notice those women having earlier signs of like hormonal issues and things like that when they have their ovaries removed?
So you're saying not removed.
Or I'm sorry,
correct?
Not removed. Yes. Yes. Yeah.
So yes. So here's the thing. If you had a removal of the uterus, a hysterectomy without your ovaries, supposedly, this shouldn't affect when you go in menopause. However, we do know, so anatomically, some of the blood supply to the ovaries comes from the uterus. Some, and the rest comes from the pelvic sidewall. And then, since we are all individuals, it depends. So if in your case, most of the blood supply came from the uterus, it's possible that after hysterectomy, I always say the ovaries take a slight hit. So that doesn't mean you go in postmenopause right then, but it might, get to you a little earlier. But, of course, that's always speculation because literally, how can we tell if it's, abnormal or not? But, it happens that women after hysterectomy, particularly if they're already like in their 40s, then suddenly, a little bit earlier than they expected, in the next 3 years, they see their last menstrual period.
Yeah.
Yes, that can happen. And I wanted to add one thing before I miss it, because, I said, well, if you after 40, that can definitely be perimenopause. However, between 40 and 45, we call it still early menopause, not abnormal, but kind of early. And I think what's really important that we are not disregarding symptoms because we say it's, this is perimenopause, because that's the new thing. In the past, no one recognized it's perimenopause in the symptoms, but now it goes to a point that women have, thyroid issues, food sensitivities, maybe gluten sensitivity, and or real autoimmune issues, and now they're being told, this is just perimenopause. So
Right.
it can go both ways. So always have someone who really listens to really evaluate what is really going on.
Yeah, absolutely. Yeah. And I think that's where that root cause approach comes in, is understanding, okay, maybe it is a little bit of perimenopause, but are there other underlying conditions that are kind of maybe flaring those symptoms and causing more issues?
Should be addressed properly.
Absolutely. Absolutely. Yeah. Instead of just being dismissed. Can women with chronic illness experience more difficult transitions? So a couple podcasts ago, I think that's what you ended up reaching out to me for, is you had seen that episode. And I know women who have chronic illnesses tend to just kind of have a rougher time with perimenopause. Do you see that that transition is more difficult for those people? And does it get better afterwards?
Well, yes, absolutely. It's worse. And no, we haven't addressed that yet. What's really happening in perimenopause? I mean, apart from, yes, the ovaries, the hormone signal becomes weaker, all of that, there is an increase in the cortisol level. So our stress system gets under pressure. And I always say, I explain it like, the body realizes, well, something is going on. Like these two co-workers, estrogen and progesterone, show up whenever they want, or they don't show up for a couple of days at all. So that puts the body under, the stress signal goes up. That has many, ramifications, from like your sleep architecture changes, and you're not so resilient to other stressors. But most importantly, once that cortisol signal goes up, it affects our metabolic health. We gain weight, we tend to lose muscle. So it's a big conundrum. And now imagine on top of it, you have a chronic illness. Let's say you already have, diabetes. That's a common one. So you already arrive in midlife when there is some metabolic changes that are not to our advantage. So now on top of that, you already have diabetes. So you're going to have more hot flashes, likely, because these insulin roller coasters that do cause hot flashes. If we have elevated cortisol levels, that stimulates the brain stem, and that gives us hot flashes. So just imagine your body is already under stress, and now comes perimenopause. So yes, absolutely. And what other things I can think of? Well, people with cardiac conditions, you already have hypertension, and now estrogen slowly moves out. So we have some, lipid changes that might be more pronounced than in a different woman. Let's say you have autoimmune disease or gut issues already. So we know that gets worse from the stress axis pressure. It gets worse because the estrobolome changes. So yes, so you basically, chronic illness puts just another layer of complexity in that transition.
Yeah. You were talking about cardiac issues, and that what triggered my brain was heart palpitations. I get a lot of women who start to notice these heart palpitations happen. Can you explain a little bit more why women in perimenopause or postmenopausal experience heart palpitations?
Yeah, that's a good one. And, I'm glad that you mentioned that, because I would say 10 years ago, that was not even recognized. So my patients would just, I know they would all go to the cardiologist, and then they would have this, Holter monitor, it's called, like for a couple of days. And, the cardiologist would say, you're okay. And however, it gives them anxiety, and so everyone needs to get that workup, of course. But I think it would have been good 10 years ago when someone would have said, this is actually most likely type of, part of that perimenopausal transition, because I had that too. And, you get panic if you never had that, and you wake up and you're basically wondering, is that the end? Am I going to have a heart attack? Is this how it starts? So now I know, right now I can tell my patients, yes, this is, part of the, the hormonal transition. Make sure you get checked out with a cardiologist, but most likely there's nothing to be found. Well, why is that? I don't think we have really good data why. I would say, if you ask my functional medicine brain, it has to do with the stress axis, that cortisol, because that feeling often comes with anxiety or even panic attacks. So I would say it just has to do with this dysregulated stress axis during that time. Because I think also it happens often at night. People wake up and have these palpitations. So, and we know these, middle of the night symptoms are very telling for that stress axis dysfunction.
Right. Well, yeah. And I mean, when you think of that, like, it's waking them up. So that now they're not getting good sleep. So they have sleep dysregulation, they have high cortisol, they have, if their blood sugar isn't regulated, all of these things are kind of downstream and causing these effects. I also have read that the cardiac muscle has a lot of estrogen receptors. And so that the estrogen, as it kind of goes on a roller coaster through perimenopause, that can also be an effect. So do you typically prescribe estrogen for those patients, or?
All right, so that's a very nuanced answer to that
Yeah.
There is so perimenopause. Again, that is a long time span. It really depends where you are. But let's say, when would I consider starting something? Let's say someone still has occasional cycles, but they have, let's say, heavy cycles or like can't sleep, anxiety. That is a good time, I think, to try progesterone only, not even estrogen yet, because in perimenopause, there's usually plenty of estrogen around. It's unbalanced. So I like to give progesterone at night. That makes the cycle lighter if that's a problem, and it helps them sleep. And we know progesterone up to 300 milligrams at night, which is a rather high dose, but we know that actually also helps with the first hot flashes. So I like to do that. And then if someone, transitions further, now the hot flashes start again, the cycles are very random or rarely, then I offer them some low dose as transdermal estrogen. And I say low dose because if people still have some ovarian function, I like to titrate it in, because there might still be some ovarian function every now and then.
Right.
So I don't want them to get overshot. That moment when suddenly the ovary decides to work again for 3 months, I don't want them to get like breast tenderness. Not that you can avoid that, and I'm telling them about it, but I kind of try to wean it in.
Yeah.
Which would be different, like someone who's already in post-menopause and has, a year no cycle or so and severe symptoms. I just give them a very reasonable dose together with the progesterone at the same time. So, however, having said this, I just want to clarify, this is not what I think everyone needs. There are most of us are good candidates, but that doesn't mean you need that. So the first thing I always look at is actually the average blood sugar of everyone who comes in my office or has any menopausal symptoms. I look at the so-called hemoglobin A1C. This is for me a very telling sign for metabolic health, and it's so important because if you have roller coasting blood sugars, you're going to have hot flashes. Every time that the blood sugar goes up, you're going to have hot flashes. And that's going to contribute to your midsection weight gain you're going to complain about. So these are the things I look first. And then I look, at your lipid markers, which is often a sign of metabolic health. So I think this is the first thing I check out. And then, there are many women, I always tell at my patients, who I saw through my career, they come just for regular checkups. They had no complaints. And many of them transition through peri and postmenopause without any issues. Yeah. Sometimes I tell them, quit the sugar. And they do that and they're like, Dr. Enzmann, this was all I needed. So, and I'm not saying this to take, the suffering away from any of the people who have symptoms. I had them too. It's just to clarify, this is not a time of where we have overt disease or we suddenly fall off the cliff and get really old. It's a natural transition. However, our life has become very stressful. So that affects how we transition through that. And we know from data that high performing and achieving women, so stressful jobs, these are the ones who suffer the most. And now we know why, because they already have this cortisol pressure going on all day. So
yeah, I've heard that the adrenals produce cortisol. Those who are high functioning, who don't have very good adrenal function, who are postmenopause, some of our hormones are made from the adrenals. So those who have drained the adrenals tend to have higher issues, more symptoms, troubles. Yeah. One person can be like, I'm juggling everything, and now one stressful day completely wipes me out. What do you recommend for those clients who are the high functioning, just go, 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 who all of a sudden wake up and they're like, I'm exhausted, I don't know how to restart this?
Yeah.
What do you recommend for them?
Well, I kind of wish they would come and ask me, not when they are like 46 and best is, once you're done with your children or you're like end of your 30s, early 40s. I think that is a moment to have a very bleak look at your life. Like, how do things look like? And you have to know, if you're not controlling your stress, that transition that's going to come can be very difficult. So, and the thing is, we don't realize how much stress we have because we're used to it. It's the modern lifestyle. We have the job and the kids and we work out and, we restrict our diet because there are so many things as women we try to straddle and struggle with at the same time. And we are not complaining. We are proudening. We tend to proud ourselves that we are able to do all of that. And I was one of them, So you really have to understand that if you're not sleeping enough, if you have a job that doesn't let you sleep, right? You're a gynecologist or an obstetrician or nurse or whatever it is, you don't get sleep. You have no time to move. And that's the other extreme. If you don't have time to move, if you're not getting enough nutrients, right? If you have been cutting calories since a long time, or you're just having a poor diet, all this contributes to stress. Then come environmental toxins, which is a all new category. And what is the other one I want? Oh, yes, and of course, and then just the stress, like the family, the friends, the job. These are often the kids that you can't control. So that really all adds up. So you should really start in midlife to think about: do I get enough sleep? Do I get the right amount of movement? What do I have? Other persons in my life that are not good for me right now. Yeah. So the difficult decisions. I'm gonna be ziplocked, right? But sometimes, you just have to say, this is not good for me anymore. And, this is when I would like people to come, like really early on. So it gives them a couple of years to kind of think, these things through. And then, however, I would say, what is the magic in perimenopause? So first of all, nutrition. Okay, of course, the stress and the sleep, but I know when you're stressed, you can't sleep. So that is kind of often difficult. However, blood sugars, this is what's going to, again, because you have a blood sugar roller coaster, the blood sugar might dip at night, then you wake up, it gives a cortisol spike. So I'm always saying, start with metabolic health. So it might be that you have to, increase your greens and veggies. That's a way to stabilize your blood sugars. Have 80% greens and veggies at every meal. That is my brief, instruction. Then if you will, indeed eating overt sugar, please let that go. Excess carbohydrates, go for whole foods carbohydrates, like, reasonable amount of fruit and, starches. So I think that is a good adjustment for many women. However, so they are the ones who need to make more time for movement. And they are the ones I see a lot. They're actually over-exercising, at least for the amount what they really take in as nutrition. And that is a new conundrum I see, that, women have been cutting calories and their basic metabolic rate adjusts over the decades. They do that. And now that doesn't work anymore. Now they are gaining weight. They're trying to cut even more. But guess what? It increases that stress signal. So now the body basically doesn't have enough extra calories to really, for, building muscle, doing all the other things. It can barely it doesn't get enough calories to do the basic metabolic functioning. So, and these women then, also exercise more because they want it, right? They are high achieving. They are like, I can do this. This worked like 10 years ago. And it gets worse and worse. Like they're losing muscle. They feel now fatigue comes, right? Yeah. That's a big one. The sleep gets even worse. They get GI issues. GI issues in menopause have many reasons, but that is one of them, definitely underfueling the body under stress. So, it gets really complex, and this is why I was saying it's difficult to tell you one
right. Absolutely.
rule. But it's really a moment to step back and have a look and see, what do I have to do to fuel my body right and give it the rest and the recovery that it really needs. How do I fuel my body right in midlife? Right. Spiritually, nutritionally, sleep, cortisol, social, all of that.
And I feel like a lot of women do feel this pull to just like, they hit this burnout or this wall and they're just like, I feel like crap. I need to make a change. And, where do I begin? And so I think those are all great places to just kind of start reevaluating, like, what don't you need in your life and what can you take away or what can you say no that is no longer serving you, that maybe one day it was, but maybe it's not. And yeah, that nutrition, the overworking, I see that a lot on cycle charts when I'm going through, they're charting their cycles and they are not ovulating because they're underfueling themselves, they're overstressing themselves, and their body just doesn't feel safe enough to ovulate. So that's where that hormonal imbalance comes in. And then you get that hormonal imbalance. They're like, oh my gosh, I'm in perimenopause. I'm like, no, you're just not fueling yourself.
Yeah.
So it's like the cycle. So then starting kind of like over and, having a clean slate and being like, okay, yes, I was type A, but now I can no longer do this. My body is telling me that I can't do this. And so we need to make a change. So I love that. For those who are over exercising, what do you recommend they maybe do to kind of still implement movement, but then maybe just take it down a notch? What do you usually recommend for those women? Or can they still do high performance, but maybe just increase their nutrition?
Yeah, so let's get to very nuanced area there. Here's what I would say. What's important to know, so strength training, muscle building is important. And cardio is the one that's probably going to be your downfall in perimenopause. I think it's important to mention this is just, it's a transition. I'm not saying you cannot increase, because we know we have very, active women when they're older. But this is just a time when you have to take a step back and look what's going on. So I would say, 3 times like strength training a week is good. And then, if you're running, you're doing extensive cardio, this might be something you have to slow down. I'm not saying you can't do it at all. I always say, well, I'm like, how do you feel afterwards?
Yeah.
Oh, I'm so exhausted. I'm like, duh, what is it you do not understand? So if, you exercise sessions don't make you feel good. It takes you 2 days to recover. There's clearly something going on.
Yeah.
So, light cardio, yes, something you enjoy. Best if you go outside, do some fast walking, that is good for you, moderate cardiovascular exercise, but it's also good for your cortisol because we know being outside is really helpful. And often it's just about, doing less sessions. I had a patient, she just did like a Peloton like 5 times a week. And finally, I convinced her to go down to 3. And she got better. And she said, I didn't realize how much these extra 2 sessions were like just kicking my rear end, Yeah. But it's often, these women don't see it until, I don't know what it is. We are just so entrained to do more and achieve more. They really need someone to put their nose right on it and then, keep hammering it in.
Yeah.
So yes, ladies. So muscle exercise is good. Some women are then every morning they get up like at 4:30 to make an hour in the gym, strength training. That's also not it. It's more is not more. Sometimes I think like, a Fitbit tracker, like an Aura ring, I have nothing to do with them. I'm just saying that gives you some insight. Are you recovered today to actually exercise? That can be hopefully insightful. So did I answer your question?
Yes,
or what?
yes, absolutely. I think there's a lot of red flags, and it's easier for outside people to maybe point those out than for you to kind of see that, like I said, like when women come to me, I see their cycles on a chart and I see what's happening and, they're charting like little emojis of working out like every single day. And I'm like, whoa, let's take a break here.
You're like, let me change the narrative. I'm not
Exactly.
sure you're understanding this right away, but
Yes.
I'll try.
Yes, absolutely. I also want to kind of touch on the gut-brain connection and really just how gut health can be really imperative, especially during perimenopause. I know a lot of women will come to me too with digestion issues, mood issues, kind of hormone related where they aren't processing or getting rid of estrogen or like I know you talked about earlier, the estrogen. Would you like to touch on that and maybe what role does, the microbiome play and how does our gut health change during perimenopause?
Yeah. So, gut as everything. It's like nuanced and complex in perimenopause. There are many things, causing issues. And you mentioned before, like the heart has estrogen receptors. I actually wanted to say already back then, most of our organs have estrogen receptors. That's why these symptoms in perimenopause, I think there are over 50 potential symptoms actually recorded. So can be all kind of things. So the gut. So one thing is that we have bacteria in our gut that are estrogen dependent, like we call it the estrobolome. So now you can imagine once that estrogen signal gets under the line, gets weaker, right? Because, I said we have like often a roller coaster of estrogen in perimenopause, but overall there is already a slight estrogen deficiency. So now these estrogen-dependent bacteria, they move out. That's how I call it. They just move out, and now it makes space for other bacteria to move in. And we basically know that the postmenopausal microbiome, gut microbiome, looks like the one of men. It doesn't mean we are men. It's just, the estrogen is gone. So the gut basically gets recolonized by other tribes. And now the question is, well, are these good or bad? So if now the territory is under stress, because now comes the gut-brain axis, which is directly they're connected with the vagus nerve. So parasympathetic state, rest and digest. So now if we are stressed, that gut is being irritated, potentially inflamed. We call it the gut-blood barrier. So, the food we eat is metabolized and then, comes out through the other end. But our gut mucosa is supposed to keep the food in the gut, and not let it come through the blood. And however, that can happen. So then little particles suddenly cross that gut-blood barrier, and now we can potentially create autoimmune reactions.
Yeah.
And why is that a problem? Because that's why gluten comes up so often. I'm not a gluten hater. It's just, unfortunately, it's a very reactive molecule. So it is the first one to easily cross that gut-blood barrier. And our body tends to create very easily autoantibodies. And these autoantibodies, unfortunately, attack other organs, like the thyroid is a typical one, just because the surface is similar. So that's an easy way to explain it. So now if you already basically the protective bacteria are moving out, some other bacteria are moving in. They are not very good for us because the territory is already angry and inflamed, if you like. So this is how, the gut symptoms start. Suddenly you have food sensitivities. Food sensitivities are a really nuisance because it's not an allergy and you don't have symptoms, or symptoms can occur until after a week until you eat one of these food items. So how can you ever figure out what it is? But it causes that, GI issues, IBS type symptoms, indigestion, bloating, constipation, all of that. And now, however, on top of this, the vagus nerve is or the parasympatheticus is basically activated the entire time. So, in German we say, like love goes through the stomach. So, or when you're, nervous, you're not hungry. Well, why is that? Because of that brain gut axis. So now if your system is under stress, it puts your gut under stress the entire time. So that's the only reason why I like the term irritable bowel syndrome, because it's true. The bowel is irritated.
Yeah.
So this is how this all, comes together. And now in terms of estrogen is metabolized in different areas. First, there are 2 steps in the liver, and then the last step to get rid of estrogen, because estrogen is well and fine, but it has to get out of the body at some point. The last step goes through the gut. So we basically poop it out. And now there is an enzyme in the gut that is able, and it's made by certain bacteria or activated by certain bacteria. That enzyme can now unpack estrogen. When it's already packed in a suitcase and supposed to get out with the next bowel movement, if you're not pooping regularly, this enzyme now gets to work and it unpacks that estrogen and lets it recirculate. And this is when you start having symptoms that we call like estrogen dominance, like you might have a migraine or breast tenderness or heavy periods. If you have fibroids that might grow, endometriosis might get worse, all of that, in perimenopause, when you think, things should kind of teeter out. Well, they don't. They first, take you on a whole ride. So that's, in rough strokes, the gut symptoms.
Yeah. I couldn't have explained it any better. I always tell my people who have gut issues, I ask them, how do you eat? Do you sit down and do you relax? And do you just enjoy your food? Or are you constantly on the go, standing up, running around in your car, shoving food in your face? Because that's the first biggest way of just implementing, okay, we're going from sympathetic to parasympathetic, right?
Yeah.
I think that's just something simple that people can do right off the bat if they are experiencing gut issues.
Yeah.
But there's definitely more, but
yeah, but that's actually, I love that. So there are actually a couple of things. So if you do nothing else, it's circadian rhythm is important too. So get up in the morning, have a big glass of warm, that's just a basic bowel regime, okay? Get up in the morning, have a big glass of water, get out in the sun, sit outside, drink it, calm down your nervous system. Then the next thing, when you eat, sit down. Exactly. Sit down, look at your food, let basically the digestive enzymes build up. Some people say, do some appreciation, take a deep breath. And that makes it clear, turn off the TV, turn up anything. You're just focusing on your meal. Then the next thing is space out your meals. 4 hours if you can. And that really to give that gut time to clean up everything between the meals, let the blood sugar come down, and then you can eat again. And then the last thing is what can really be helpful is, if it's an easy overnight fast, which not 16, not 18 hours, none of that, because your cortisol is already up. But let's say 12 hours, you stop eating at 7 and then you eat again at 7 or even 9. This is easily done. And that gives that gut, time to clean up, to do all the homework that has to be done. So, and I think many GI issues can literally be fixed, get improved a lot with doing that first.
I couldn't agree more. And I think a lot of people who start to implement those things, they instantly feel better. And it also helps with blood sugar too. So the two are kind of working hand in hand.
Yes.
So yeah. And even like going for like a postprandial walk or after dinner or a large meal, you go for a walk that helps to move that blood sugar into the muscles instead of the bloodstream. And all of these things that we're talking about kind of go hand in hand and work together. So getting those basics down kind of will support you through this perimenopausal time.
Movement, I wanted to mention, movement is also important for bowel movement. So if you sit on your rear end all day long and then you have stress, you're not going to be able to poop. And then, the solution is not more laxatives. It's really get up and move, do something, take a walk. Exactly.
I would like to kind of switch gears. And I know that you really love talking about the genitourinary syndromes of menopause. And so I would like to just kind of dive into that area. So what exactly is a genitourinary syndrome and how do you recognize it in patients?
So first, the term sounds very technical, but it was really an acknowledgement of the medical societies that this is not just, it was called before just vaginal atrophy. And then, physicians were like, oh, whatever, she has pain with sex, what do we care? This is kind of a lifestyle problem. So then, the gynecologists were like, well, no, this is not just the vagina. It also affects the bladder because the bladder has estrogen receptors too. And so we're going to call it genitourinary syndrome of menopause. And that kind of elevated this, out of that. This is just a personal problem. So I really like that we did that, that renaming.
Mm-hmm.
So it means a vagina has, of course, plenty of estrogen receptors and part of the bladder. So what's happening now if the vagina doesn't see estrogen stimulation for a long time, that tissue gets, I want to say, thinner and more friable. So usually the vagina is really that, the tube that has this lush pink tissue. It's stretchy. It has several folds. And, it can stretch. It can have intercourse. It can accommodate babies. It does all kind of crazy things. And, heals very well. Everyone who had, childbirth injuries, this is actually a miracle. So, however, estrogen does that. It keeps that all pliable. And it also helps the bladder to be nice and flexible. So, meaning now when the estrogen goes away, the bladder is not as stretchy anymore. When it was like a big balloon, now it's a smaller balloon. And now the tiniest amount of urine, the bladder is immediately going to contract and say, oh, this irritates me already. Go out, go out. And we have suddenly a urinary frequency or urge, or maybe even an urge incontinence. So we pee a little bit on ourselves. We just hear the water trickling or we think about the toilet and oops, there's already a little wetness in our underwear. So that is the urinary part of it. And then the vagina, we have, dryness, recurrent urinary tract infections, also because that tissue can't protect itself. It's not like thick anymore. So recurrent urinary tract infections, pain with intercourse, or, just dryness. Some women don't even have sex. They're like, it feels dry down there. It bothers me. And then it can, you're just more susceptible to other irritants, I say. Is it the perineal pads or the washing routine you have been doing since 50 years and suddenly causes all kind of infections? So this is because the vagina really can't defend itself so well anymore. And the interesting thing is that the genitourinary syndrome of menopause is typically described like something that happens once you have been in post-menopause for a while. Like, because this estrogen lacking effect takes a while. However, I really see it a lot, and I talk to other practitioners. It's often the earliest sign. So women in their early to mid 40s suddenly having urinary tract infections. having some more dryness, which I think is kind of interesting, but it's consistent with what other people are really observing. And it's even more pronounced in women who haven't born children vaginally. Let's say they have no children or had C-sections, because, these women additionally didn't have that extra stretching everyone else is getting.
Right.
So these tissues, this extra tightening is felt immediately. So these women are the earliest to have actually pain with intercourse. The other ones I see more this urinary tract infection. What I want to mention here on this occasion is some really young women get the same symptoms, and this is when they have been a long time on birth control pills, particularly when that has been started very young. I have nothing against birth control pills. I'm just describing you something that I've seen a lot. So particularly women, when they start the pill like 16 or 17, because let's say they had really painful cycles. So I would do the same thing. I just warn them now. And then, in their early 20s, they suddenly get literally pain with intercourse, or they are diagnosed with vaginismus or vestibulitis. And you're just wondering, like, why? It's because these vaginas never got like this full up estrogenization in like the late teens, and they get that very early. And the easiest fix, instead of doing all kind of crazy things, is literally stop the birth control pill. Stop it for a couple of months, and then there are different formulations. But people don't know that. So I really want to throw this out there. And of course, that can happen too if you start the birth control pill later, but you'd say you have been on it, for 10 or 15 years. And, again, you can have that these tissues are lacking these hormones. And what I need to explain is, we always think, well, we take a birth control pill, we think automatically this is extra hormone. We have a lot of hormones. That's not really the case, because instead of your own roller coaster of monthly hormones, and Ashley knows everything about it, instead of that, this is actually suppressed. So you're going to have a rather low level of stable hormones every day, 365. And this is what in the end causes these estrogen deficiency symptoms in your vagina.
Also, this can happen postpartum when women are breastfeeding, and that is due to low estrogen as well.
Yes.
So a lot of women will come to me postpartum. They're like, oh my gosh, it's so dry down there. And I'm like, this is normal because that HPO axis is shut off. And the same thing happens with birth control too. When they're coming to you, what do you do? Like, what are the things that are commonly missed or available for them?
Yeah. So the good thing about that GSM, genitourinary syndrome of menopause, it's easily to fix. That's kind of the easiest one. And we do this with topical estrogens or DHEA, which is a type of testosterone. So topical means you just stuff it in the vagina in form of tablets, creams, rings. And what's important to explain, this is not systemic hormone. This doesn't count as HRT, and you literally can take this until the end of your days. And in the past, until like when that labeling was removed a couple of months ago, unfortunately, the vaginal hormones came with that same warning because they got a class labeling. And so women would always get confused because I give them vaginal estrogen and it's saying like it's causing your breast cancer and maybe a stroke. And I'm like, this, it caused me that I had to talk a lot and, had to hope that they trust me and that they know that I know what I'm doing. So that was removed, which I'm very happy in regard to that. So so the vaginal hormones, they are not absorbed or barely absorbed initially until that tissue really thickens up. And there have been studies that have shown there's no measurable hormone level. So in theory, that could even be safe if you had hormone-sensitive breast cancer. However, that's the official statement of the Menopause Society. But just be aware, ultimately, your oncologist is the one who rules. And in my experience, they're usually very careful and don't know about, they're just, again, but it's worthwhile a conversation with your gynecologist and oncologist if nothing else helps, okay? And if vaginal estrogen, often many women get it prescribed now, and then comes the next pitfall. They're not getting enough. So, whoever prescribes is super careful. And then they get 2 doses a week. And I'm like, well, that's not, that can be enough if you are also on systemic hormones or you just need a little bit. But if someone who has really severe pain with intercourse, the penis doesn't even go in, this is not going to do it. So these women need much persistent use for a while. So for example, someone who really can have no penetration, it's tremendously painful. I use actually the cream initially. It's kind of messy, but I like it because you get the, the product in the vagina, and you can apply it outside to the vulva where the penis goes in, everything that's tender. And you do that really for 3 weeks every night, persistently. But that's good enough. 3 weeks is really good. And then I say, well, let's try to have intercourse with a good lubricant. We can talk about lubricants in a sec. and then I'm like, well, now you can taper down. Probably 3 times a week is going to be enough. And maybe we can also use a different formulation, something that is less messy. Even some people love the cream that just makes them feel good.
Yeah.
So again, often just not enough is given if you think that really didn't help them. So that's what I would like to mention.
Yeah, with that cream, if they are having intercourse, do you recommend that they apply it after intercourse? So will that contact with the penis cause,
I get it. It's a great question. Yeah. Because, so I always say, well, the penis really doesn't need extra estrogen. So, so how do you do it, right? So if you have infrequently intercourse, it's not an issue. But, some women are like, well, how do I know? So I would say it's better to use it after intercourse, right? So because you don't want to get it on him necessarily. And sometimes I'm saying, well, maybe also the vaginal tablets are easier. They are not, they don't create so much substance that kind of floating in the vagina. There's one product I like for that reason particularly. It's actually what's called intrarosa or DHEA. You can also compound it, vaginal DHEA. Why do I like it? It's actually that adrenal testosterone that you mentioned earlier, Ashley. Yeah. So it helps the vaginal tissue, as does vaginal estrogen. And however, it's a type of testosterone. So I'm saying, well, if you use that, you can get it on your husband's penis too. That's going to be good for him too. So I love that particularly, actually the prescription one is like a little fat-based suppository, which I really like. Everything that's fat-based, it basically has less other ingredients. So it's less reactive with the vagina. So I like it. I think you can even use it kind of as a lubricant, insert it prior to intercourse. It makes it really nice and slippery. And, it's DHA. Right. So this is really my favorite. It's not covered by all insurances. That the copay tends to be higher. Many of my patients think it's well worth it. But again, it's good to have options.
Do you notice that the tissue then, so instead of atrophying, does it come back? Like, do they regain that tissue?
I apologize that I haven't mentioned that. Absolutely. Yeah. So that vagina is going to come back to be nice and pink and has the fold and it's moist. Absolutely. And you can prevent recurrent urinary tract infections with that. That urinary frequency is going to go away. So there are different types of incontinence. It's like the urge, like when you have to go, right? And that's where estrogen really help well. The other one is the stress incontinence. That is more when you cough or you sneeze, you suddenly leak. And this usually that has to do with an anatomic laxity of your pelvic floor. Let's just call it like that, which can usually happen with childbirth, but it can also just happen because, okay?
Right.
And this is when that estrogen is actually not going to help. The other things are more helpful, like pessary, for example, or to see a urogynecologist who has like much more great tools in his armamentarium.
Yeah. Well, and just going to pelvic floor therapy too. That can be a very helpful thing.
Thank you. Actually, I want to say I apologize. This is actually the first thing I would do and is so successful. Like, I'm so happy that this has become a real thing, pelvic floor physical therapy. Even like, prolapse, it can be so much improved that functionally you don't have issues. So definitely pelvic floor physical therapy. I love these ladies who do that.
Yeah. Yes. I know. I mean, even just like 10 or 15 years ago, pelvic floor therapy was barely a thing in the United States. And so it's like now I love how we're just talking more about it and it's more open and there's so many other options for you. As far as non-hormonal options, and I know you wanted to quickly discuss lube, do you recommend like vulva balms and like making sure that blood flow gets to that area, all of that?
Definitely. So yes. So first of all, if you use the vagina frequently, like you have sex or you have, you use a dildo or whatever it is, so that is going to increase blood flow. And that means you might not need estrogen or much less. So how the vagina works in post-menopause depends on how much you use it, and that on that dependent is how much estrogen you need additionally. So, and I also want to mention there are women, they have no issues at all. Again, it's you're not all. And why? I don't know. I look at these vaginas; they look kind of pale, but they have space and they have sex with no problems. Maybe they convert hormones different on the cellular level. We don't know. So, but just so you know, don't everyone get panicky about this. Just see what's going to happen. And if you're going to have issues, there are solutions out there. So basically have sex if you can, or, do something to pleasure yourself. That's going to be helpful. Then for outside for the vulva, what I really like is emu oil. That is an oil made from that bird from Australia, emus. And it's tremendously, so it has the right omega fatty acids, and it's super anti-inflammatory. That's actually used a lot in massage therapy as well as pelvic floor rehabilitation. So emu oil is one of my favorite ones. I also say argan oil, sea buckthorn oil. All of these are strongly anti-inflammatory, and you can just apply it to your vulva or even the introitus. It might be all you need to have sex. So that is one. Then there are formulations that you can compound with vitamin E, for example, for the vagina, hyaluronic acid. Here, always, what I mentioned before. So the more stuff they put in this product, the more it can irritate you. So we know that, like the gut barrier we mentioned earlier, the vaginal mucosa also has a barrier. So if we irritate this with so many ingredients, you are setting yourself up for irritation. So I like things that are very pure, like pure oil or something in a fat base. I'm not a big fan of creams in general. Even I mentioned that estrogen cream, that is an exception.
Yeah. Yeah,
so
absolutely.
that, and then, for intercourse, you want this to be comfortable, right? Because the moment you have pain, your brain is going to say, please do not do that again. We can't have that. So lubricants, in 2014, there was a report from the World Health Organization. They already had examined that, and they said most water-based lubricants, the osmolality is too high. What that means the density of the molecules in that product is so high that it actually pulls water out of the cells of your vagina. So it might feel good in the first moment, but in the second step, it's actually dehydrating the cells. It's cytotoxic. And so the industry hasn't really responded. Very few organizations actually really now record osmolality or even mention that. So that means even really good, water-based lubricants I used to recommend that are like clinical or whatever, it didn't matter at all. It was really too hyperosmolar. And that's when patients are coming, like, this feels good. But then, I get irritated. I'm like, yeah, I know why. So one company out there, it's Good Clean Love, and I'm their medical advisor since many years. Was
wonderful.
Happy story when we met. So they actually control for osmolality, and these products were actually made by a Johns Hopkins vaginal microbiome researcher. So Richard Cohen. So that was him. So anyway, these are really good water-based. Water-based, however, you have to know it can be very slippery initially, and everything water-based dries up at a certain point. So depending how much lubrication you need, it might feel okay, and then it gets dry again, and you have to reapply. And then everything water-based is going to be metabolized by vaginal bacteria. So it has the right osmolality and the right ingredients. So for that reason, I'm a big fan of, in that case, for the vagina, some silicone-based. I know you usually don't like silicone, but for the vagina, I have nothing against it. And there is one out there, I have nothing to do with them. It's Überloop. My patients love that. That is now silicone or hybrid based. It's not metabolized by the vaginal microbiome at all. It's just, and it's slippery from the beginning to the end, to a point where I always tell my patients, if you shower after sex, so be careful you don't have that stuff on your feet because you are going to fall. However, if you're with, most of your listeners are too young for that. But if you have a really dry, everything has been hurting for many years, you want this intercourse to you want no friction at all initially. And this is why, I love that silicone base. So anyhow, everyone has to pick what works for them.
Yeah. I also want to touch on, so a lot of times the reasons in perimenopause and postmenopausal, cervical fluid dries up. So cervical fluid, we talk about a lot in all my courses and things like that. But cervical fluid is you talked about friability. The cervix can also get friable, but it stops producing when we don't have enough estrogen, it stops producing cervical fluid, and that's another reason. So when we don't have lubricant down there, it's because we don't have a ton of cervical fluid, most likely as well, because of that estrogen changing. And so that can also cause things. I do want to just quickly touch also on, intercourse. Obviously, as we get older, we have to really it's not just an act, it has to become more of a mental connection. And so connecting with your partner more mentally rather than just physically, I think can be really important as well to just kind of talk about. And even like tantra and energy, working with those aspects with intercourse in the later ages, I think is important than, when we were in our 20s and we could just do it and be good, right? And achieve. But it gets a lot more, you have to be more creative as we age. So.
Yeah. And I think, it's exactly right what you're saying. I have patients, they're the low libido, right? Everyone takes to have that. And they are often very distraught. And it's like they think it needs to go back like when they were 20. And I'm like, actually, first, some women continue to, but just the stress, all of these things cause, some issue. However, then women, they are kind of basically giving up on sex because they don't have that tremendous libido anymore. And then I'm always asking, well, do you have pain when you have intercourse, or when you have? And then often they're like, no, it's actually okay. And then I'm like, well, can you still orgasm? In case you were orgasming before. Yes, when we finally do it, I do. So I'm like, it's a commitment to your partnership in midlife. So you might not feel like, you have this like when you were 20, but it's nice. This is something that connects you to your partner. This is when your partner feels like you are their woman. So, and we know from, Master Johnson, this model of sexual arousal that initially said like, well, first there comes the stimulus in your head and then comes the lubrication. And, we long revised that. We know if you don't have that libido initially, but you just start doing it, you can still, have that outcome. So it doesn't matter. You can kind of enter wherever that is. So you can as well just decide, okay, we have a date night tonight and we are going to have sex because I love my partner.
Right.
And then again, once you do it, and this is nice, it creates that, the oxytocin bond, and it lubricates your vagina. So yes, I agree with you. It needs to be, often it's a mind shift we have to do. And then there needs to be a little commitment. And of course, stress reduction is always.
Well, and taking the stress away of also saying, we're going to have a date night tonight, but it doesn't always have to end in intercourse. It could end in just connection too. So there's the duality of that. So
yeah. We have all different relationships,
yes.
Whatever it is that makes you happy. Yes.
Absolutely. Well, I want to just touch finally on the other side of perimenopause, because I know this is where your bread and butter is. I think that this is also a conversation that those who are going through a rough time need to hear. They need to understand that it's not just about surviving, it's about how we can thrive afterwards. So I guess really, can you share a little bit about what does thriving in your 50s, 60s, and beyond look like for, those who are really wanting to kind of improve that later in life outlook?
Yeah. So thriving I don't think it's much different than when you were younger. It's just, you have a little bit more wisdom. That is, I think, the benefit. So there is some clarity. And then, I have no pains. I can work out. I'm in control of my life at this point. I have changed my job a couple of times. Now I work for myself. That's the clarity part. But I don't feel less energetic than when I was in my 30s. So just to clarify this. So it's, there, and now you have this control in your life. My kids are out of the house with, or like today they are, of course, they are moving and like, even I told them don't move today because it's not good for me, but, so, but I think you learn these boundaries that you don't even realize you don't have them when you're younger. Like even if you're a person that was not good with boundaries like myself, suddenly I have them very clear in my head. It's like, no, this is like your problem. It's not my problem. And this is tremendously freeing. And, many women like myself, they start new businesses. They see things, they start new things. So I think it's a tremendous opportunity for us women when, this, I want to call it burden of reproduction. I don't hope this doesn't rub you the wrong way, but it's lovely as long as you're in there because that's all you know. But later on, you're like, wow, this is a hard job, ladies. I'm glad that you're taking care of this right now because I don't want to have this anymore. So it's lovely on the other side. So I think there is beauty in a woman's life all around, if we're younger or older. And, what we have to learn is just to step back and take good care of ourselves and the woman around us, because I think that's what we have a hard time learning, but maybe it's going to come.
Absolutely. I love that. And I love knowing that if you want it, like you have to kind of take action in order to get that. But you can totally achieve a long, happy, healthy lifestyle, post-menopausal. It doesn't have to just look like, you're kind of stuck under a rock, but you really have to take initiative to kind of move that way and feel better and do all of the lifestyle habits that come
there's
with that.
actually but that's actually real data behind it. It's from the Menopause Society. So they actually did interviews with women, and 70% of postmenopausal women actually said that they were happier than they were in their 30s and 40s. So imagine. So it's not a time of disease or anything. It's a time of readjustment when you have to start to listen to your body and maybe, spiritually a little bit. Who are you? What do you want? And that's really a chance for us to, to do something entirely else or whatever. You want to do something better or just do what you really like to do. So that's really what it is.
I love that. I have a couple rapid fire questions and then we'll wrap up. What is the biggest myth about menopause?
That this is just about hot flashes and normal menstrual cycles.
One thing every woman over 40 should prioritize.
Sleep and low blood sugar nutrition.
Yes, I would agree. One health habit that's overrated.
I don't want to say exercise, but I kind of want to say exercise.
Yeah.
So in terms of exercise, more is more. Let's say it like this.
Yes.
So that's what's overrated. That the more exercise is more.
Absolutely. The most underrated lifestyle habit.
Going to bed early.
One book or resource every woman should read.
Oh, well, I have a book that is being translated. So I have a book, it's called Somebody Told Me. It's in German, was published in 2024. It's going to be now translated to Russian, actually. So it's really quite popular in Germany. And I'm translating it right now. So it's going to come out in the US, I would say September. So check it out.
So your book, yes, I love that.
Somebody told me everything about nutrition and lifestyle in perimenopause. So you know what it's about, yes.
Wonderful. What's one thing you wish every woman knew before the age of 40?
Well, that if she is not adjusting her stress, her body is going to take her on a ride that she is not going to like.
If someone listening feels like she is losing herself right now, what would you want her to know about the woman she is becoming?
She is going to become a fantastic version of herself, much clearer. And in the way, if you feel lost, look for someone who can help you. Look for, a good physician, a therapist, look for Ashley, or someone who can, tell you you're not alone. This is just our experience. Yes.
Finally, where can listeners find you? Can they work with you? Are there any restrictions on any of that?
Yeah. So you can find me under my website, drchristinaenzmann.com. And you can write me an email, contact@drchristinaenzmann.com. I'm mostly doing online functional medicine work. So you can reach me from everywhere. In that case, I'm your health coach. And as a physician, I work in Maryland. So that's when I can prescribe and I do see patients in person in Maryland.
Perfect. Yeah. And you said that you are a post-menopausal coach or provider, like you're under the society, correct?
Yeah. We had so many good things to talk about. Exactly.
Yes.
I'm certified menopause practitioner, so that's really what I do all day long.
Yes.
And then vulvovaginal disease. Yes.
Wonderful. Wonderful. Okay. I absolutely love this conversation because it reminds us that menopause isn't the end of vitality. It's a transition into a new season of life. Yes, our hormones change, but that doesn't mean our health, energy, or quality life have to decline. My hope is that today's episode gave you practical tools, hope, and confidence to begin asking questions, advocating for yourself, and remembering that your body isn't working against you. It's asking for different kinds of support. If you enjoyed this episode, I'd love for you to share it with friends who are navigating this season. And if you're ready to better understand your own hormones through cycle charting or body literacy, you can connect with me through the links in the show notes. I will also have Dr. Enzmann's information as well. Until next time, keep listening to your body. It has incredible wisdom to share. We'll see you next week.
Bye-bye.
Thanks.